So I'm not a physiologist. I have a very strong interest in physiology, but I'm a lung physician by training, and I'm going to show you some cases, interesting cases, slightly out of the ordinary that we saw in our lung function lab, which is exercise testing lab, which is mainly for sick people. So just so I get a little bit of a feel, how many of you, just by show of hands, feel comfortable at least looking at the report of a clinical exercise test? Okay, how many don't? Okay, not too many. All right, so let's go. And let's look at this first case, which is Mr. A, a 65-year-old gentleman with the anthropomorphics that you see before you. So he's essentially normal weight, and he has a pretty respectable smoking history of 80 pack years, and he's been short of breath for about 6 years, and he now has difficulty climbing one flight of stairs. One of the problems that we have with this population is they say, oh, 65, I'm old. I shouldn't be able to climb more than one flight of stairs anymore. It's okay, and they forget about this little detail here, right? But we want to know what's wrong with this guy. What's limiting his exercise capacity? So here's his spirometry, which shows a very mild obstructive defect, maybe by a somewhat low F1 FVC ratio. At his age, that's actually probably even within normal limits. So questionable mild obstructive defect, and he does not have a significant bronchodilator response.
0.72 is for the predicted or the absolute?
0.72 is the FEV1 in liters as a ratio to the FVC in liters, not percent predicted. 0.72.
For this age.
For that age, it's low towards the lower limit. And his peak VO2 is 64% predicted, so he has an exercise limitation, right? So, but what is his problem? So when we look at the cardiovascular response, all right, he gets to a peak heart rate of 118, which is 76% predicted, and a heart rate reserve of 37 beats per minute. His peak O2 pulse is 84% predicted, which is pretty decent. He has a plateau of the O2 pulse curve as a function of time. His RER at the peak is 1.08, which, as Omri told you before, does not indicate cardiovascular limitation. We were not able to identify an anaerobic threshold. He probably didn't reach it, or he was just on the verge of it. And his electrocardiogram was unremarkable. And so this is what we see. We see that little bit of a flattening there, this is the V slope, which we can't see. It seems to have the red dots, which are the VCO2, seem to have be about linear and without a breaking there. And so we couldn't identify. You can see that there, the line through the VCO2, and we couldn't identify an AT. So basically, we say, okay, there's no clear cardiovascular exhaustion here. This patient does not seem to have exhausted his cardiovascular system. How about his ventilatory response? He's a heavy smoker, right? So his peak respiratory rate was 36, which isn't too high. He had a peak tidal volume of 67% of his inspiratory capacity at rest. He had a breathing reserve of 38% of his MVV, 43 liters per minute, no ventilatory limitation at all. But look at his gas exchange. So his oxygen saturation decreased a little bit, which isn't too bad. Sometimes in people who are very fit and reach high levels of exercise and they have normal physiology, we see a little bit of a decrease in the oxygen saturation. But we shouldn't really see that, so that's not normal. The most important finding is the VVCO2. So we're looking at, that's a mistake, I'm sorry. We should have, he didn't reach his AT. We should have a lowest value of about 30. Okay, and you can see here, all right, VVCO2 is the red dots, and this is the axis. So he's way up there and not decreasing with exercise. So he has abnormal gas exchange. His end-tidal CO2 at rest is 29, and at peak exercise decreases to 26, which is lower than we would expect. So he has abnormal gas exchange. So what's the differential diagnosis of abnormal gas exchange? We can see it in parenchymal lung disease or in pulmonary vascular disease. Pulmonary vascular disease referring to diseases that primarily or exclusively affect the blood vessels of the lung. And the mechanism there of the abnormal gas exchange is VQ mismatch. We also see it in psychogenic hyperventilation in people who, for neurotic reasons, breathe rapidly and shallowly, and then their VD-VT ratio, okay, their dead space is relatively high because of the mandatory anatomical dead space. So if you have a rapid shallow breathing pattern, you're going to be expending a lot of your minute ventilation on dead space.
But here's what 37, which is low.
So why is this patient limited? What's his problem? Okay? So he has near normal spirometry, which would seem to rule out, right, significant lung disease. He has normal echocardiography with no evidence of pulmonary hypertension, so he doesn't seem to have pulmonary vascular disease. He has nothing to suggest psychogenic hyperventilation. So going back to the differential diagnosis, what is wrong with this guy? But if we look at the complete lung function report, okay, we see this I showed you before, the spirometry. He's got a normal total lung capacity, but he's got an elevated residual volume, an elevated FRC suggesting air trapping, and he's got a DLCO of 50%, moderately reduced. And what's the explanation for all of that? This is a lung CT showing emphysema. So you see that it's heterogeneous. The color is heterogeneous. And there are areas here which are much blacker. These are the normal areas here, almost normal. They're not completely normal. And this is severe emphysema. So you might ask me, okay, why does this patient not have an obstructive defect? And the answer is I don't know. But we know that the pathophysiology emphysema is a loss of elastic recoil, which causes airflow resistance, air trapping, and hyperinflation. But there's also the component of the destruction of the alveoli, which causes ventilation perfusion mismatch, which is really what's causing this guy's problem. So the take-home message is that while for many applications of CPET, spirometry is enough, if you're evaluating unexplained dyspnea, if that's the indication for your CPET, you probably should do full lung function testing. Spirometry, volumes, and DLCO at least. Another case, 24-year-old guy, closer to what's seen in Wingate perhaps, basketball coach, never smoked. In childhood there was some questionable history of asthma. He had orthopedic surgery when he was 12. This is wrong, it was 12. From the age of 18, he had progressive dyspnea, and he was found to have pulmonary emboli and treated with anticoagulants, or what some of the people call blood thinners. And when he was worked up for why this occurred, he was found to have an autoimmune disease called antiphospholipid syndrome. The antiphospholipid antibodies interfere with the clotting system, and these patients develop pulmonary emboli. So he's pretty limited, and again, this is a sporty guy. He's on the basketball court and used to be a player, but stopped playing because he couldn't. And here is lung function. So he's got slightly reduced, okay? None of the values are, well, the vital capacity is within normal range. He seems to have combined restrictive and obstructive pattern. Why? 0.76 is a little low for someone at the age of 24, but he's also got a slightly reduced DLC, a slightly reduced FRC, and he certainly has a reduced DLCO, moderately reduced. And his peak VO2 is 76% predicted. Now remember, those norms, we use the Wasserman norms, those are calculated for people who are sedentary, and this is a guy who's quite active, so we would be expecting not 100% with him, but 110, 120, 130. He's not an elite athlete, but we would certainly be expecting more. So he's significantly below what we would expect. So here's his cardiovascular response, okay? He has a heart rate reserve of 16, 91% predicted. His peak VO2 heart rate is 81% predicted. We can see that there's the flattening of the curve there. His RER at the peak is 1.1 in this test. His anaerobic threshold is a little low. And again, in an athlete, you'd expect it to be relatively high. And he has incomplete right bundle branch block in the electrocardiogram with no ischemic changes. We wouldn't expect them, but no ischemic changes during exercise. So he seems to have reached a cardiovascular limit. But look at this. He also seems to have a ventilatory limitation. He gets up to 55 breaths a minute, which is pretty high. His peak tidal volume is 81% of his inspiratory capacity. And his breathing reserve is 2 liters per minute. He's got no breathing reserve. So he seems to have a ventilatory limitation. But let's look at his gas exchange. He drops his saturation down to 85. Okay, you can see that there. And his end-tidal CO2, which at rest is 30, at peak exercise is 22. He's working very hard to achieve what he achieved. His VFeCO2, where's that? Here, doesn't move. It's high, 40. It should be at his age, 26, something like that. And it doesn't move, doesn't go down. He should be going through exercise, recruiting more of his capillary bed, and his VFeCO2 should be dropping. It's not dropping at all. So the CPET summary is that he has mildly reduced exercise capacity, okay, and in absolute terms at least. He has cardiovascular and ventilatory exhaustion, or near to it. Cardiovascular is close, the ventilatory is full. And he has very abnormal gas exchange, which is consistent with pulmonary vascular disease. But the treatment for his disease is open heart surgery. And so we weren't really sure what we should do with this guy. He had imaging which showed evidence of chronic thromboembolic disease. His echocardiography was normal, okay? Normal right ventricular function, no pulmonary hypertension. We did a right heart catheterization for invasive hemodynamics. I'm not sure how many of you are familiar with these values, but they're basically essentially normal. In fact, for his age, his PA pressure is a little bit higher than it should be, and his cardiac index of 2.7, that's the cardiac index is cardiac output normalized to body surface area. So it's kind of low normal, and again, in an athlete, we would expect it to be high normal or high. And his pulmonary vascular resistance is within normal limits. So what do we do with this guy? What do we do now? So we decided to adopt a strategy which in Hebrew is called hamishkal v'ayam, and in English is called wait and see. So then this is what happened. We repeated, he's kind of disappeared a little bit. He heard me say something about open heart surgery, so he kind of disappeared for a while. But then he came back, and so look what happens 2 years later. Okay, his peak VO2 has now gone down to 60%. His anaerobic threshold has gone from 38% of his predicted peak VO2 to 33%, going down. And in this period, he was trying to train as much as he could because he was trying to run away from the cardiac surgeons, okay? His lung function is decreasing a bit, but that doesn't seem to be, in retrospect, I can tell you that is probably a consequence of his vascular disease and not a cause of his vascular disease. Look at the RER, he was trying to prove to me that he's okay. So he got to an RER of 1.4. Okay, really a maximal test. His breathing reserve is now negative. His VFeCO2 is still sky high, and his oxygen saturation is still decreasing with exercise. So we said, all right, we have to refer this guy for surgery. We repeated the echocardiogram, normal. We repeated the hemodynamics by right heart catheterization, normal. But we had the imaging showing that he has the obstruction of the large vessels that is typical of his disease. Okay, so what do we do now? We referred him for surgery, which he had in February 2015, and this is a surgery called a pulmonary endarterectomy. The surgeon basically is cleaning out this junk from the pulmonary arteries, but it's no longer blood clots. Blood clots are quite easy to remove if you know what you're doing, if you're a surgeon. You open the artery and you can basically suck them out. But here we're talking about, and you can see this image, but this is not from his surgery, it's from Google. But you can see what it looks like. It's white, it's fibrotic tissue, it's what we call organized thrombus, but it's not fibrin and platelets anymore. It's collagen cells, it's scar tissue. Okay, and this is done with full cardiopulmonary bypass, with periods of circulatory arrest when they're actually doing the dissection, and they have to find an endarterectomy plane between this stuff and the media of the artery, and they do, of course, both lungs. And then, what do we get? We get a guy who's back on the basketball court, who can now sprint. He couldn't sprint before, and it'd be an interesting question to try and think of how he could run slowly. Before surgery, he could still run 8 kilometers, but slowly. And when he picked up speed, he couldn't do that anymore, and he couldn't sprint at all. And we see here, and the most dramatic finding is he now does have a bit of a breathing reserve, and his where's his VVCO2? His VVCO2 has dropped. His ventilatory efficiency has improved significantly. He's up to 70% peak VO2, so he's improved. Is he healthy? No, he's not healthy, but he's feeling a lot better. He's back on the basketball court, and he's doing well. So, right, so that's what I told you. The take-home message of this is that it's kind of an unusual case of ventilatory limitation caused by a very high ventilatory demand because of extremely inefficient ventilation, it's very abnormal gas exchange. And CPET is in this case, as we show in this case, that it's a very sensitive tool for detecting progression of disease. Because I remind you that the echo was normal, the hemodynamics were essentially normal and did not progress. The cardiopulmonary did progress, and that was what made us say, this guy needs surgery. And he is now, I asked him, every time I see him, I ask him, are you satisfied with the surgery? Do you think it was a good idea? Because I didn't sleep for several weeks when he was having the surgery, referring this guy, 24-year-old guy, for open heart surgery with normal hemodynamics. And he says, yes, absolutely, I'm happy. I'm much more closer to doing what I want to do. Just one more brief case, which I call The Little Engine That Could, if some of you are familiar with that children's book, one of the great books of my childhood. 63-year-old female with COPD. She's an ex-smoker, and she was referred to us for evaluation before enrollment in pulmonary rehab because she has COPD. And this is her lung function, and she's pretty sick. She has an FEV1 of 49% predicted. With bronchodilators, she goes up to 57. Her ratio is 0.48, very low. Okay? She has a DLCO of 48% predicted. She has a normal TLC, so no hyperinflation, but she does have air traffic, significant air traffic. And this is her ventilatory response to exercise. So she has a breathing reserve of 3 liters. Her peak tidal volume to IC ratio is 0.73, which is okay. VVCO2 is high. She desaturates with exercise. So she's really a sick woman, as we would expect from her lung functions. But look at this. Okay, that's just showing you the ventilator. I'll move on. And this is, Ronen did a study. By the way, when Ronen says it can and should be done, he's right. But doing these tests properly is something which is a little tricky, and which Ronen has spent a lot of effort working on. And Ronen is a highly experienced CPET physiologist. So we see here again that there's dynamic hyperinflation, right? The end expiratory lung volume is moving left, where in a normal person it would move right. And the inspiratory reserve volume, which I've showed on this side, which is at the 0 watts, here is already getting to the half-liter range, which, as we learned from Ken O'Donnell's work, is getting very close to the limit. So she's definitely ventilatory limitation. But why is she an interesting case and not just yet another COPD patient? Because look at this. Her peak VO2 is 107% predicted. Okay? Look at her anaerobic threshold, 77% of her predicted VO2 peak. So, this woman has above average exercise, that's why I call her the little engine that could. She has above average exercise capacity. And she's overcoming a ventilatory limitation and abnormal gas exchange because she has extraordinarily good cardiovascular aerobic fitness, which enables her to do more for less. Why do I say that? Because if you have high aerobic capacity, okay, your ventilatory demand for a given task is lower, and then even if you have a ventilatory limitation, you can still do more work. And that is what, in fact, is probably behind most of the benefit we see from exercise training in people who are ventilatory limited in principle. We shouldn't be able to do anything. We shouldn't be able to improve them. But yes, we are. And the mechanism of that improvement is that we improve their aerobic capacity and reduce the ventilatory demand. There's a supply and demand issue. The supply we can't improve, but the demand we can. Thank you very much for your attention.